MDMA-assisted psychotherapy for PTSD. I just want to ask quickly how many of you know that this is now in phase 3 trials with the FDA? So, pretty exciting stuff, right? So, my name is Lindsay Kent. I am a documentary filmmaker. I focus on conscious media. And I had the great pleasure of working with MAPSS on a video and interview with a guy named John Saul, who I just saw somewhere. And he came out the other end of this study with a really profound and positive experience. And it's just one of just so many experiences, and this is just the start. So I'd like to start with my amazing panelists to my left. Can you guys talk about what brought you to this medicine and what you do?
Sure. Well, luckily I already had buyers at the talk. So again, I had a profound shift towards this, towards medicine work through 5-MeO, but I had previous experiences before that and felt very called to want to give back to the community and work towards helping more people to be able to get access to these substances in a way. So if people want to use these for their own personal growth and their healing, that they have access to that in a safe and reliable way.
My name is Dr. Cole Marta. I'm a psychiatrist in private practice in Los Angeles and Santa Barbara. And I'm also the principal investigator on the MDMA-assisted psychotherapy PTSD site in Los Angeles as part of the phase 3 trials. And how I got here is I was raised by deadheads, and then I went to medical school. And they're actually here and patiently listening to this panel despite having Dark Star Orchestra show to go to in Ohio, so trying to get through it.
So I'm also the study coordinator for the MDMA clinical trial here in LA, so Cole's my boss.
I'm Dr. Barone. I'm a psychologist in Oakland, California. I run an inpatient psychiatric care facility, and I've been working in a variety of contexts with the MDMA. Worked with MAPSS for the last 5 or 6 years. Started volunteering when I started my doctorate program, and then did my dissertation that turned into the first qualitative investigation of MDMA-assisted psychotherapy. So we have a couple parts of that, our posters in the back. I can go into that more if anyone wants to talk about what came out of the 1-year follow-up program from MDMA. Also, I'm an adherence leader for phase 3. So we're a part of the team helping the therapists on the protocol, working on the study.
Awesome, yeah, and make sure to speak into the mic so we can talk about what we did. All right, so guys, tell me, why MDMA and why PTSD? Why do these two work together?
One of the things that's so unique about MDMA is that it keeps in a really narrow, really workable tolerance window for therapy. So you're creating a strong bond. Anyone who's done MDMA knows that it causes bonding between people. So you're creating a really strong bond with your therapist, which that therapeutic bubble can take years and years and years to build something where someone feels safe to be able to get vulnerable to walk amongst whatever it is that they're working through. While at the same time, people are staying kind of alert and engaged in wanting to talk, but it's also lowering the activity in the amygdala, which is where your fear response is regulated. So for PTSD, what happens is you get when you think about the experience or you're trying to repress that experience, you're getting reactivated. So MDMA allows you to talk about really triggering material, but without going into that fear response that would take you out of that therapeutic window. So it's a really beautiful medicine for this particular condition.
And drawing back to Dr. Early's presentation, it's almost like a cheat code for a secure attachment relationship. It's something terrible would have to happen for the therapist. It has to be connect well with the participant who was under the influence of MDMA. So on top of those neurobiological effects, you also have a supercharged, almost therapeutic alliance developed between the therapist and the participant that would otherwise take a long, long time to develop. And the number one outcome of all mental health treatment is not the style of therapy, not even the medications that they use. That a therapeutic alliance is the number one predictor of outcomes. So that's certainly a big part that sometimes doesn't get discussed as much.
Yeah, and I think a big reason of why they chose PTSD, or why it seems to work so well with this therapy, is looking at PTSD is one of the harder things to treat. The traditional therapies that we've been using really just haven't been working very well. And so in a number of the panels and talks that have come up this weekend, it's been good to hear people talking about two different stratospheres of treating trauma, where you can have the side of using medications or using different skills to cover up some of the symptoms that come up, but you're not really working on the underlying reason why those symptoms are coming out. And so that's usually where medications come in. People are taking a large amount of medications. Often when they're coming into the studies, some people are taking upwards of 15, 20 medications coming in, and we have people going through on 0 medications when they leave the study. So that's the role where medications often come in, where psychotherapy is usually taken the role is trying to get at those underlying systems that are causing the symptoms. But what comes up in that is it's just incredibly difficult to start opening up these traumas after you've built so much protection around them. So what the MDMA therapy does is it comes in and it puts these two systems together to allow someone to undergo the therapy process in a way that they are mitigated by the effects that they were speaking about, able to process the trauma in a way that they never have before. So they're able to get to the trauma underneath, clear it out, process it, and that is what we see lead to the long-term healing.
Awesome. So where did this all start? What studies have been done, and what have the outcomes been so far?
So there have been a handful of phase 2 studies that have already been done, which is the first. Is everybody familiar with the phases of FDA?
Maybe tell them.
So quickly, when you're actually trying to bring a drug to market through the FDA approval process, there's 3 stages, and different fields of medicine have different definitions for that. But for mental health, the first stage is giving the drug to healthy volunteers, looking at parameters that may be of concern for safety. The second phase is the first time you're actually testing your original hypothesis that this medicine may be helpful for this condition. So at this point with MDMA, MDMA-assisted psychotherapy for PTSD, there have been a handful of phase 2 studies done which were incredibly promising. 2 of them have been published at this point. The first was done with primarily victims of sexual abuse, and the second study was done to show or to test whether or not it'd be also helpful for combat veterans, police, and firemen. And so the second study, follow-up study, was exclusively veterans, police, and firefighters. And they had actually similar results, which were, I believe the first study had an 83% success rate, and the second study was comparable to that. And the amount of, something that really stands out, and I think gets missed a lot in communicating like scientific papers, is when we're talking about a treatment for PTSD, that can be anything that shows some amount of benefit. So there are a lot of treatments for PTSD, and what gets lost is the effect size. So somebody taking prazosin for nightmares, their sleep quality is improved. It's measurably different than somebody who doesn't have nightly nightmares or has more frequent nightmares. But people are going from dysfunctional to functional because of these small changes. The MDMA effect size is like enormous. It's really impressive. People are having dramatic changes. People are going from non-functional to functional, and that is really, really exciting.
Do you have some stats that you can share?
Well, and I just wanted to add to that so the study that I took part in was going 1 year after that phase 2 study with veterans, police, and firefighters, and looking at how these results lasted over the next year. And really, it was a qualitative study, so this is the first time we were able to look at really how the participants were describing their experience in the study, what they felt was beneficial, what they felt could be better, and look at dozens of parameters that changed for them. So while there is really robust evidence in seeing the CAPS scores, so seeing their PTSD symptoms change, and that does last over a year for many of the participants, actually what we found was such a large part of our sample went from being in the highest severity of PTSD and treatment resistant, where they've tried other therapies before, being in that higher level to after the 3 sessions being not diagnosable for PTSD at the end of the study. And then we found 1 year later that a good portion of those continued to be under diagnostic criteria 1 year after the study. So that's pretty amazing. But beyond that, what we found in the qualitative study is that there's more to the story than just the CAPS scores. So even though the PTSD symptoms are much improved, even people who didn't show drastic change in their CAPS scores still said every problem they had in their life was better after doing the study. So we're just starting to look into the other sides of this that are beneficial also.
I think the compiled data of all of the phase 2 studies had like 2/3 of people having a significant response, or I forget what the term was that they used, which is really important, sustained remission. 2/3 of people who participated in a handful of phase 2 studies. So now we're at the point where we're gearing up and about to start the phase 3 studies, which is the last step in the process of getting the FDA to approve MDMA as an actual prescribable medicine. And there is even a preemptive signed agreement that as long as we meet particular data criteria that we're very confident we're going to be able to meet, especially as long as things go something like the phase 2 studies, that they signed a contract basically saying that nothing will get in the way of it becoming a medicine. If we can meet these study criteria, then MDMA will become a available treatment. So
It's
almost there.
so close. And this is really monumental because nothing has ever come off the Schedule 1 substance list. Not even marijuana, right? And at this rate, we may beat marijuana. So it's huge. It's really huge, and so at in terms of the timeline, we're going to be starting officially phase 3 this summer, and it will be about a year and a half for us to complete phase 3. But if the numbers again look like we expect them to look in phase 2, we might be able to go into what's called expanded access. So maybe to that for a minute. Yeah.
At that point, we're going to need an army of psychotherapists trained in MDMA-assisted psychotherapy for PTSD, because there are hundreds and hundreds of people who are expressing interest in getting this treatment. And as far as the amount of participants we're going to be able to see in the study, we're talking in the dozens. So it's going to be really important that everybody who's interested in becoming a psychedelic psychotherapist, that is a real job that might be available to you very soon. So keep your eyes out. And I just wanted to say something about that nothing has ever come off of the Schedule 1 list before. Like, so much about this has never been done before. You know, the meeting with the FDA, it's like they don't have a chapter in their manual on like, what if somebody thought this was a medicine? So, like, every step has been trying to coordinate with these huge bureaucracies, like things that nobody expected to ever happen. So
we have to make entirely new insurance codes because something like this exists. And how do we interface this with the existing insurance systems so that people can actually afford this therapy, because it is going to be very expensive because it's a lot of face time with therapists, but at the same time it's going to be considerably less expensive than something like TMS or something like that.
Or giving somebody 10 medicines for the rest of their life.
Right.
And just so, you know, you said 2/3 of people are coming out in remission from, sorry.
So yeah, and in the phase 2 clinical trials, around 2/3 of people, all the people in the phase 2 trials had chronic treatment-resistant PTSD, and I think the average time that they had PTSD was like, 15 years or something?
Over 10 years.
Yeah, and after 3 treatments with MDMA-assisted psychotherapy, 2/3 of people were not diagnosable with PTSD afterwards.
And this is just huge compared to any other treatment PTSD ever.
It's huge. It's just
Nothing has come close.
Yeah, even close.
So we're going to move ahead a little bit, but walk us through what this procedure looks like, how you choose people, what it looks like leading up to the actual dose, what the dose looks like, and then the treatment afterward.
So I'll kind of start that. So we're, right now I believe we've had maybe 1,300 people apply to be in our study so far in Los Angeles. We can, for this first part we're doing right now, we can take 4 people. And then the next part in phase 3 is going to be about 20-ish. So there's clearly a huge interest in this.
Good job security if you're planning on being a psychotherapist.
So we have a strict criteria on what people, when people can be accepted into the trial. We can't tell you what the criteria are, unfortunately, because if we told you, then maybe you would lie to get into the study. So, but people go through a phone screening, and then they then they have a follow-up call with the therapist. And if they've met all those requirements, then they come and meet with the therapy team. They go through a battery of different testing, both psychological and physical and medical testing, because we're trying to collect a whole bunch of baseline data around their psychological well-being beforehand so that we can measure it as they go through the process of doing the therapy.
So once somebody tolerates that incredible screening process, then we start the actual therapy, and from here out is most likely what it would look like should it come to market. So we meet with people to prepare them. So we have 3 preparatory sessions, and after the 3 preparatory sessions, we have what we call our experimental day, and that's an 8 to 10 hour day where the participant ingests the MDMA. We measure some parameters in the morning to ensure safety, but they sit then with their co-therapist paired. Right now, the model is a male-female therapy dyad, so there are always 2 people present in the preparatory sessions in medicine. After the medicine session, there will be 3 integration sessions where you talk about the experience that occurred during the medicine session, as well as anything else that has come up since the medicine session, integrating the insights, and then that is repeated. So you'll have a medicine session, 3 integration, medicine session, 3 integration, and a 3rd medicine session, and then 3 integration/termination sessions. And so In total is 15 visits, 3 of them where there's actually MDMA ingested, and that's 8 or 10 hours a day, and the rest of the visits are about 90 minutes long.
And within the clinical trials, that gets a little more complicated when you take into account the blinding and that part of the sample is not getting full dose MDMA as a control. But what happens is after they go through the phase that Cole just described, then everybody is offered full dose MDMA sessions on the same protocol. So if someone goes through and gets the low dose MDMA, which is an inactive dose, as a placebo control, after they so this was phase 2. So in the new one, there's not a low dose.
Yeah, it's just straight up.
But then they're offered the full dose sessions. Right.
So you get a lot of therapy during your placebo. And so actually, I mean, some of the people that went through the phase 2 clinical trials and got the placebo first, went through this whole process, and then went and did the whole medicine. So it's like you got it twice. They actually, it actually worked really nice for them because they got double the amount of therapy. So good for them to actually like, oh yeah, placebo, because they get that acid definitely.
I mean, and I'm sure a lot of us here know how important second setting is. Are you able to touch a little bit on what the dose days look like? I don't know if that's classified.
No, it's not. It's so I'm not I don't even notice aesthetics. Like I don't know, something's wrong with my vision or something. But luckily, the rest of my team is amazing, and I notice it when it's there as opposed to not there. But I don't know what kind of magic made it happen.
What makes it pretty?
Yeah, exactly. Like.
So yeah, we were trying to create a space that feels inviting. It's much more kind of like a living room, you know. And we have art materials and music is a very key part of this process. So one of the therapists on the therapy dyad has an extensive curated music library to help people support their process as they go through. So, and sometimes you can kind of support them going deeper into their process by using music. So music is used for that whole time. Sometimes people will be engaging in having a conversation with the therapy team, and there's often times that we kind of encourage people to go into their experiences. So they put eye shades on and headphones, and then they go into kind of an inward space, and they come out and process that a little bit. And so you kind of modulate between this sort of inward time and outward time. And one of the key parts of the protocol is that we're using a non-directive approach. So we're not using like a particular type of therapy, because we want to try and see the effect of the drug itself without being, associated with either cognitive behavioral therapy or gestalt or something like that, because we're not measuring that. But the kind of main sort of philosophy is that we're encouraging people to go into their experience and trust their kind of inner healing intelligence to guide them. And so the therapists are kind of following the lead of the participant in their unfolding process. Cool. So.
Yeah, and I would just add to that just briefly that, and a big part, and I think all of us have probably watched a number of sessions, so a big part of what the therapists are there for is to just really hold that safe space, to really be non-judgmental on what comes up, to really see that, to hold that space is anything that comes up, you have this team here to hold you, and that's really reflected in how participants respond to the therapy teams. So a big part of the setting is the relationship in that, and MDMA, one of the great parts about it is it really facilitates the relationship between people. It's one of the things that we know very well about MDMA. For example, in the study with police and firefighters with post-traumatic stress disorder, it's probably one of the hardest populations to develop a rapport with. So that was a big thing that we found in the study is how quickly that's developed and how important that is.
So let's talk about the future of this. What does the future look like when I won't say it, because when this gets approved? What will this medicine look like in the world, in the U.S., globally?
We build lots of clinics. And we need to get insurance up to speed so that anyone can get access to this treatment. We need trained therapists to be ready to do this work. So we're working on building a clinic here in Los Angeles right now.
The next would be the potentially expanded access program, which is one of the really beautiful things that I've learned during this whole process is that the FDA actually has some really intelligent plans. Just move incredibly slowly, but they've been through this process with all kinds of drugs, and so a lot of the concerns we might have had are ones that they're very familiar with. So one would be that this process is really, really slow, and we have this potentially game-changing medicine that we're going to be sitting around waiting for another 2 years to finish this process. So they have an internal process called expanded access, and what you can do is actually have your data analyzed at some point before finishing, like maybe a third of the way through the study. It's predetermined. And they will unblind the data by an independent party, and the independent party will assess whether it's met predetermined criteria for promise, and then there becomes this ethical obligation to not wait until this medication is finished with the entire process. So that is something that we're pretty confident that we would meet the criteria for, and so in the nearer future, we may not even be waiting the 18 months or 2 years or so that we're expecting to finish the study before we're going to need a lot more therapists.
Yeah, and so beyond expanded access and when it opens up after 2021, it can look a number of different ways, but there are parameters that each facility is going to need to have to be able to engage in this therapy. And so, as far as I know right now, MAPSS is the only group that's going to be training therapists, and that's going to be the situation going forward, which is a really good thing, I think. But there's a number of ways that you can set up a clinic, so it's going to be potential where you could have one prescriber in a clinic and multiple therapy teams, and that doesn't necessarily have to be a psychologist or a psychiatrist. There's a few different levels of people who can actually be part of the therapy team, and I know they're trying to engage people in training, so there's a lot of ways to get involved in participating.
And a question that I was actually being asked earlier and I didn't know how to answer, so maybe you guys have some thoughts on it, but people, two people come up and ask me about what this might look like in community mental health, because a lot of what their calls have been for like people that are in private practice to do this, but in expanded access, how can people that are in community mental health start to engage this process?
The answer to that is within the realm of the insurance companies and how billing codes are made and agreements are made between companies that buy insurance, and it's fantastically boring. So unless people are really passionate about the exact answer, just know it's buried in there. It's possible that there can be relationships and negotiations and partnerships made with community mental health centers to be able to provide a treatment like this if those matters are handled correctly.
So it would be something like people would get referred out to do it rather than MDMA assisted psychotherapy for PTSD happening within a existing community mental health center.
That's actually how most DMH processes already work. Like there are a few like mental health centers that are run by the county, but there is a lot of community partnerships with nonprofit organizations, research programs that are proposing, for example, solutions to homelessness that involve mental health, and they contract with the county. So that kind of thing would be actually within the normal realm of functioning.
Yeah, I think I wanted to ask, there are some difficulties with this treatment that make it kind of hard to do in certain contexts. That is, even though it only takes between 3 and 4 months to really go through the entire process, which is really short when you consider treatment for PTSD, there's a lot of time with the therapist. There's a lot of engagement. And on the nights of that MDMA sessions, you do have to be able to stay overnight in the facility. So the facility has to have certain parameters that it can reach. But there are some models that people are looking at to try and get around some of the difficulties with getting insurance involved. One of those might be having a really wide sliding scale where other things are offered at higher costs that can fill in for some low cost or free options for that.
So how do people get involved? Maybe they want to enroll in the study, or they want to help in some other way through MAPSS. What's the protocol there?
If you want to enroll in the study and you have PTSD, you can look on the MAPSS website or on clinicaltrials.gov and find your closest MDMA clinical trial site. And email them or give them a phone call and let them know you're interested. But keep in mind that, I already said we've already got over 1,000 people that have are interested in this, and it's so, not to be too discouraging, but there are a lot of people, so you may or may not get a response.
Yeah, and the MAPSS, if you sign up with MAPSS, you can sign up for a newsletter so that you get an announcement when each trial site opens. And phase 3, like if you look on clinicaltrials.gov right now, you'll see this smaller study that we're finishing right now, or getting close to finishing. And so if you've already expressed an interest, you'll have to express interest again for the phase 3 trial running over. It's like a separate entity. So that process is going to start over in most likely August or September. So keep your, get the updates from MAPSS, and clinicaltrials.gov is also a website where it will tell you where all the locations are, the contact information for each of the locations, and where they are in the recruitment process. So you can also track when they open recruitment, whether they're actively recruiting or they've finished recruiting. So that's a place to get updates as well.
And as far as participating in the research side or helping out, being part of the study team or doing some of the research, there's a number of ways to get involved there. One thing is, after we finish our qualitative study for the phase 2, we're designing the phase 3 qualitative follow-up study, which is going to be a giant study, which is going to need a lot of people. So that's something we really want to recruit as many students as we can that want to be involved in this research and get experience doing qualitative research, being involved in the studies. It's really amazing work. It's really hard work. I've been working on that study the last 5 years. And it's been a massive labor of love. It's amazing that that one's come to fruition. But so now we're setting that up. But beyond that, I think just being involved in this community and things like this, volunteering with MAPSS, volunteering with other organizations as much as you can. And what I found, what I tell people is if you're going to get into it, volunteer for as many things as you can and go in and do it well. Meet as many people as you can. Don't take on too much, but when you take on, do it as well as you can. And sometimes it's just you're in the right place at the right time, and things open up, and you wind up doing something you never thought you would.
Do you have to be a therapist to be a psychedelic therapist? To learn how to be a psychedelic therapist?
That's a good question that is not resolved. Right now, I would say if you are contemplating I would recommend getting a licensure. It is more than likely going to require a licensure once this comes to market. Some of the, as I understand it, some of the large national organizations for different kinds of therapy styles, like licensed clinical social workers, LMFTs, they're going to be pretty. They're really attached, obviously, to what is called therapy and what is not. And so if we're going to continue to call this therapy and do therapy, and we're actually providing therapy, then it will most likely require people who are licensed in one of those therapy schools of therapy.
Yeah.
Therapy.
But where there is more room is participating in the research side. So I've seen people from a lot of different disciplines get involved in the research. We can use mathematicians, we can use researchers, we can use social workers, a whole lot of different things, or even just being really interested in doing it, willing to put in the work. There's a lot of work to be done.
Any closing remarks before we open it up to the audience, guys?
I would say that one of the things that's, because we're up to this point, all of the money that has gone to fund this research, and most of it has been around for 30 years, has all been come from private funding, which is completely unheard of. It's a non-profit pharmaceutical company. When we get this rescheduled, it will open up for us to get funding from the government to do research, and that's when we're going to have this blossoming of research, is when we can actually get funding from the government. So the research is going to explode once we get this rescheduled.
And that is historic, and everybody in the community should be proud of themselves. And this has never happened.
Yeah, it's
Never
huge.
before
It's
have
huge.
donations, nickels and dimes added up to so big.
Awesome. Give it up, guys, for this amazing panel. If you have questions, if you guys want to line up on the sides.
Question about you rate attachment and security, categorize the patients by the style of attachment and security they have, what measures you use. Does that have an impact on outcome?
We don't formally. There are a lot of opportunities, in this particular research project, but we don't rate people's attachment. We don't address it directly, but I would say definitely thinking in the right realm, like the attachment is a big part of what we're doing. But
All fare the same.
I was gonna say, it can look a lot of different ways, and people are bringing a lot of different attachment styles. So a lot of the traumas that have come from different places, different lifestyles, but even the vets, police, and firefighters that came in, we found that almost all of them had an early childhood trauma and attachment issues that was dealt with a lot in the room. And so what we saw was a lot of attachment issues being resolved or worked on with the medicine. So we'd see people that are insecure with the connection they have with the therapist, questioning it and seeing that resolved in the room. And the medicine is something that can really facilitate that conversation without the fear, without the self-judgment, while it's kind of sitting on the surface, but you're able to work with it and work through it.
One of the things that's the beauty of having the male-female dyad, and one of the kind of weird sort of thing is you don't necessarily know if you're going to need mom or dad in your experience. So you're having a healing experience in relation to sort of a masculine or a feminine figure, and so you can kind of play out and work through a lot of issues depending on that, based off of this kind of unique therapy protocol.
Thank you so much for all of your work. I'd like to ask, what will be the role of psychiatrists after the completion of clinical trials? What do you think about the emerging paradigm of psychoactive assisted psychotherapy and the future potential there? And lastly, do any of you dare to use the word cure for PTSD? Thank you.
I'm supposed to use that word. Sustained remission.
Psychiatry question. I think that's going to be an individual decision of every psychiatrist, but there will be a necessary role of psychiatrists on every team to be a license holder so that you can have medicine at the facility, because the treatment will take place in the facility. So regardless of the schedule that the medicine is, it will have to be stored in a particular way. They'll have to have a medical doctor, and they'll have to also prescribe that particular medicine. So it can be as minimal as exactly that, or for those psychiatrists who are interested in curious people, they probably want to do more than just that, and they can also become a therapist. They can become one of the providing therapists.
Can a nurse that can prescribe medication, could they replace the psychiatrist in the setting? That or is it?
That is probably not something that's quite worked out yet, because those vary from state to state as well, what the prescribing powers are of nurse practitioners and physician assistants. So that's something that's probably yet to be seen. But if it's treated in the same way, my guess is that ultimately an MD will still be overseeing that nurse practitioner or physician assistant.
Yeah, and I just real quick, there's something important for the second things that you asked. So, the reason we refer to this as MDMA-assisted psychotherapy is because the therapy component is the important component. So an important thing to think about, or the way I think about it, is that it's not the MDMA that's causing this change. The MDMA is allowing the therapy to happen, and the therapy is what's causing the change. So that looks different than some of the traditional psychedelics. So that's important. And then as for calling it a cure, I don't know anyone who does that generally, but what we found is, even though there is sustained remission for many of the people who go through it, we found that in the people who did have some rebound in symptoms in the following year, often that's nowhere near where they were at the beginning of the study. But in our 1-year follow-up, 5 of the 6 people who had some rebound in symptoms had some major stressor or life event or another trauma in the year following. So just to know, even if you don't have symptoms anymore, these are people who are likely susceptible to developing PTSD again. So that's something we're looking at going forward, is how to make this more robust and protect against those factors in the future.
I would recommend anyone who's very interested in that ongoing process. With our project hosted Rachel Hope, who went through one of the phase 2 clinical trials, and she gave an excellent talk on her process going through it, and then afterwards, and the need for, it's an ongoing journey. It's not just, okay, three times and you're done. So you can find that on the Onward Project website.
All that said, I've seen participants describing this cure.
Hi, I'm a functional medicine or integrated psychiatrist. I've been following MDMA for many, many years. Great panel. Kudos to Rick Doblin for being a champion for years and years, and it was really difficult.
Rick!
Love the guy. Anyway, I have a couple questions. One is, what's the manufacturing and marketing model in terms of it's being a pharmaceutical, how's it being distributed? It's a whole big other thing to deal with. I'm sure you're into it. The other question is, Are you giving any supplements to people? For example, in the old days we would give people 5-HTP, tryptophan, B vitamins, and so on to help them restore their transmitters afterwards.
So because of the particular context of the clinical trial, we have to be really careful not to introduce confounding factors. So as far as recovery supplements, it's not included and actually forbidden in this context, but I think it's not a bad thing once it comes to market. What was it?
It's further research. How?
Oh yeah, so right now, drugs that come to market have to be manufactured in a very specific way. Good manufacturing practices is the term that the FDA oversees. And the MDMA we've been using for all of the studies so far is MDMA manufactured by David Nichols in 1983. It's the same pile of MDMA that we are using in the studies that today. So that wasn't done in good manufacturing practices, unfortunately.
Which is mostly just the documentation process, because I mean that medicine has been tested and it's very, very pure. Yeah, but the thing is that you have to go through this very rigorous process of documenting every single step of the way. So that's the good manufacturing. It's mostly paperwork.
Yeah, and you have to show that that you're going to be able to make as much as might be needed. It doesn't do us any good if we say we've got this breakthrough, amazing treatment, and we can only make a tiny bit at a time. So those kinds of regulatory things are happening right now. And as far as the marketing, I think it kind of solves itself.
People like drugs.
I think David Nichols also emphasized on the psilocybin in his studies.
Thank you.
Hi, thank you so much for all the work that you guys are doing. How, besides PTSD, are there any studies out there for resistant treatment for depressive patients, anxiety, addiction?
So far the clinical trials have looked into, so primarily PTSD was treatment-resistant chronic PTSD was the first main one. It's also been looked at in anxiety associated with chronic end-of-life anxiety, so nearing death with illness. And then it's also been protocols out for high-functioning autism.
So it's also been looked at to help people that have social anxiety that are on the autism spectrum. So you're not curing autism, but you're helping people on the autism spectrum with social anxiety. So those data should be coming out very soon.
And there's likely promise that it would be useful for a broader spectrum of things, but because the entire MAPSS research engine is being run on donor money, all the resources are being concentrated on this one thing. And once it gets over the finish line, actually physicians who get the ability to prescribe it, they can, if they have reason to believe it might be helpful for something else, there are ways for them to use it off-label, and that's a normal practice, particularly in psychiatry. Yeah. Insurance purposes, that insurances will probably try to wiggle out of paying for it if there isn't sufficient evidence. So, it would be, perhaps you could win that battle with them, perhaps not. It could be a reason to formally do a phase 2 study for a particular condition.
Another tricky aspect of this too is, when this was originally used for therapy before it was made legal in the 80s, it was used very effectively for couples therapy. The thing is that couples therapy and marital dysfunction is not a diagnosable, it's not in the DSM, and so we can't say, MDMA for couples therapy because it's not it's not a diagnosis. So we're kind of limited by this structure that we have.
But there is a study that's starting for couples where
Right.
one of the couple has PTSD.
So it's like a sneaky.
So that's starting. But yeah, like Cole said, when it gets over the line where it's no longer a Schedule 1 substance, it should open up the doors for a lot of phase 2 trials to look into
Tons of research.
which will hopefully get it to where insurance can cover those things.
All sorts of things.
Where Charles wrote shows psilocybin for his new life studies that they're considering MDMA. I think they decided against it because of hardware toxicity, but what do you guys think about that?
They are using it, so there was one phase 2 study, and they are in the 1-year follow-up phase right now, so I'm helping to develop the long-term follow-up qualitative study for that right now. I don't have the results of that.
I do actually. I just want to say really quick that John Saul, where are you? Was in that study. He was diagnosed with a life-threatening illness, and he can tell you all about it, but I also have a 5-minute film on it, but he basically just spent years not being able to get out of bed, was in so much pain, and now he runs I don't know how many miles a day in sand. He's a yoga teacher. He feels great.
Thumbs up or thumbs down? Thumbs up?
Yeah, I'm pretty sure he enjoyed it. And had never taken MDMA in his life and quit a bunch of pain pills cold turkey for months before, so he could be a part of the study because he just knew that it would help, and he has a really amazing story. I would definitely ask.
And asterisk, don't get off your medication if you want to get onto the study. Because we need to get baseline and we need to make sure you're tapering properly, and if you get off your medications before you can actually, that may actually get you from coming on. So just because you're on medications doesn't mean you can't get into the study. So yeah, don't do that. And also John gave a talk at the AWARE Project, so if you want to hear more about his story, you can also go to the AWARE Project channel.
Thank you all. Just a quick question. So you went over some of the key elements and the process for the dose sessions. What about the placebo sessions? Were those done in the same way?
Yeah.
Yes.
Both is a quick question. Excellent question.
I have a question too. How does a good licensed psychotherapist get trained? Would I get onto the project website?
Get onto the MAPSS mailing list. CIAS, Janice, who came to talk yesterday, CIAS is working with MAPSS to develop this assisted psychotherapy training program. And so everyone who's interested in doing this work has to go through one of these programs. And so one of the other therapists who actually works with Cole in their therapy dyad, Shannon, is leading this training program. So get involved in that.
I do have one other question. I work with cult survivors. 99% of them have PTSD. Would any of you be interested in doing research?
Well, if any of them you feel meets criteria for PTSD, it would be an interesting contribution to the participant pool, and also because they're human beings who deserve to feel good.
Amen.
I mean, the interest in research is, we're all interested, so, if you're interested in working with, stay involved.
Actually, thanks again for everything you guys are doing. I have a question that might seem a little nitpicky, but you were speaking of PTSD clients who had chronic PTSD. Is that the same as complex PTSD, extensive dissociation?
Yeah. So chronic PTSD would just speak to the length of time. It's a long-running diagnosis of PTSD, where complex PTSD is often talked about with multiple traumas or long-term situation leads to hypervigilance. So that's generally what we refer to as complex PTSD. It's generally very, very hard to treat. Our study didn't necessarily separate those, so there was a bit of discipline.
So we don't really know.
So somebody with complex PTSD is likely to have chronic PTSD because complex PTSD comes from repeated traumatic experiences. For example, someone growing up was serially assaulted by a horrible person, so that kind of person will likely develop chronic PTSD symptoms, but also complex PTSD symptoms. So, but somebody who had one terrible car accident 15 years ago and has forever been stuck in their house because they're afraid of any motor vehicles, that person can have chronic PTSD, but not necessarily complex PTSD.
So what does it do anything for people who are severely dissociated? So my question is,
Yeah, I mean, disassociation is often associated with trauma, but what we're looking at right now is more PTSD rather than a diagnosis with disassociation. So at this time, we're trying to focus more on that, and in the future, we can look more at its effect on disassociation.
Yeah, dissociation, just like Ashley said, dissociation can be a symptom of PTSD, and that could potentially qualify, but yeah.
Yes, thank you for your talk. My question is similar to the previous question, but a little bit more narrow. Say an MFT wants to participate, wants to become a therapist on the therapist team. How important is it for that person to actually do this process, take medications or seminars? Or would it be better for them not to?
Good question. It sounds like you understand why an argument would go either way. And that argument exists. And people feel strongly about it in both directions. And right now the push is to certainly have as many people who are going to be doing this have a personal experience with MDMA. In fact, there's a separate study that is approved for people who are training to do MDMA-assisted psychotherapy for PTSD, which right now are just the people who are on the study teams, to have an experience of their own. And there's another camp, in a controlled study with that collecting and then there's another camp who sees value in having, aren't necessarily, who don't necessarily believe you should have to have that experience.
Thank you.
Thank you very much, guys. It's really a great panel.